Hello, good afternoon, everyone, and greetings from Venus Medicine Research Center. There's a warm welcome to all our speakers and the audience for being present in today's webinar, Soup to Nuts of Antibiotic Breakpoints. This webinar is a sincere effort to bridge the gap between the microbiological perception and the clinical outlook towards antibiotic sensitivity testing and breakpoints. Before we move forward to the session, let me introduce myself to you. I'm Dr. Pankaj Mandale, acting as the Senior Director of Medical Affairs for Venus Medicine Research Center. I will be your host and the moderator for today's webinar session. After my welcome speech, the session will be handed to our CEO of VMRC, Mr. Saransh Chaudhary, who will share his views on VMRC, then followed by the session topics by Dr. Camilla Rodisman.
Good afternoon, ladies and gentlemen. On behalf of VMRC, it is my pleasure to welcome you all to today's webinar on soup to nuts of antibiotic breakpoints. For those of you who are not familiar with Venus Medicine Research Center or VMRC, please allow me to give a brief introduction. VMRC is the research wing of Venus Remedies Limited and was set up in 2004 with the aim to find innovative solutions to the challenge of AMR. Since our inception, we have worked on a multitude of approaches, including BL-BLI combinations, antibiotic resistance breakers, novel drug delivery techniques, and novel formulation techniques with the singular aim of addressing the unmet medical need of AMR. With a state-of-the-art research facility, VMRC was among the first in India to be accredited by DSIR, obtained GLP accreditations for multiple preclinical labs, and a CPSCA-approved animal house. Over the years, we have added super specialty labs to advance our understanding of bacterial infectious diseases like hollow fiber infection models and, for the first time in India, organ-in-chip models. We have always viewed AMR as a huge public health crisis that needs to be dealt with on an immediate basis and at all levels of the healthcare setup. And the concept of antibiotic breakpoints is critical for the appropriate use of antibiotics in clinical settings. Yet, this remains a highly complex area due to the ever-evolving scientific and regulatory landscape. The content for this webinar was drafted and curated by an expert panel to provide you with a thorough understanding of how to establish and interpret antibiotic breakpoints. Before I leave, I would like to take this opportunity to thank you all the doctors, the healthcare workers, paramedics, and all support staff who have worked tirelessly over the past year and given their all in the fight against COVID-19. Please accept my heartfelt gratitude. And with that, I would like to hand it over to Dr. Pankaj Mandale to initiate the proceedings for the webinar. Thank you all.
So let's begin with our first topic for this webinar of soups to nuts of antibiotic breakpoints. May I welcome our first speaker, Dr. Rahul Kamble. Dr. Rahul Kamble is a consultant microbiologist and infection control head at Lilavati Hospital and Research Center at Mumbai. He has more than 12 years of experience in clinical microbiology and infection control. His expertise include infectious disease control and antimicrobial stewardship. He has numerous academic certifications and diplomas from international organizations of repute, like the Harvard Medical School and the UNSW Australia. He has been an active member of antimicrobial stewardship program for the best hospitals in India, like the Lilavati Hospital and Research Center, which he is working currently, along with Asian Heart Hospital and the Hinduja Healthcare Hospital, Mumbai. He is also an JCI and NABL internal auditor, along with the very prestigious Six Sigma belt certification. So back to you, Dr. Rahul Kamble, sir. Please take over. Thank you.
Thanks, Dr. Pankaj, for a very good introduction. I wish everyone here a very good afternoon to all. A special thanks to the team of Venus Remedies for giving me the opportunity to speak on one of my favorite topic, that is conducting and interpreting antimicrobial susceptibility testing. And it's indeed a pleasure to speak with the stalwarts of microbiology and infectious disease here in this webinar. It's a very short time that I'll be speaking on, so we'll try to cover most of the main points through this webinar. In this session, I'll be covering the different methods of antimicrobial susceptibility testing and how to interpret the results obtained from these testings. Then I'll be covering on the agencies that determine the breakpoints, how to establish the breakpoints will be the main body of this session, that is establishing the epidemiological cutoff, how to establish the peaky pharmacokinetic pharmacodynamic indices, and the in vitro in vivo correlation. And finally, we'll conclude with the guidelines for therapeutic decision based on antimicrobial susceptibility test results. So I begin hereby. Let us first understand why we do the antimicrobial susceptibility testing. Main reason for the application of the antimicrobial susceptibility testing is for the selection of appropriate treatment. We use the results obtained from the antimicrobial susceptibility testing, whether it is a qualitative or quantitative, for the selection of an appropriate antibiotic. Based on the MIC results, it also helps us to that for the dosing of the antimicrobial. The frequency and the dose can be determined from the results of the antimicrobial susceptibility testing. The second application of the antimicrobial susceptibility testing is to monitor the development of resistance. Through AST, we determine the resistance mechanisms present in a resistant bacteria or microorganisms like ESBL, that is extended spectrum beta lactamase, or MRSA, or VRE, or AMC, or MBL. So these AST results help us to monitor the resistance of development. What is the resistance at the present level, and what was it in the past? So it helps us to monitor the resistance of development. Then detection of new resistance mechanisms is another application of antimicrobial susceptibility testing. Then the resistance patterns we compare among different geographical areas. We compare from hospital to hospital, and within different geographical areas, and then at the state level, and then at the country level, and at the global level, we compare the antibiogram and the sensitive pattern of different organisms. And finally, we get a huge data from the antimicrobial susceptibility testing. What we do with this data, we put in interventions to prevent the development of resistance. So we see what was the resistance before the application of the interventions, and what interventions made an impact on the resistance pattern, and that interventions we then apply to our antimicrobial stewardship programs. Apart from the selection of the antibiotic and monitoring the resistance patterns and developing intervention strategies in the form of antimicrobial stewardship strategies, other application of antimicrobial susceptibility testing is for research projects also. The antimicrobial resistance pattern can help us for the typing of the microorganism. The typing can further be used for epidemiological purposes such as outbreak investigations. That was about the applications of the antimicrobial susceptibility testing. Now, we can do this antimicrobial susceptibility testing by two methods, either by phenotypic methods or by genotypic method. The issue with the genotypic method is that the resistance is not based only on the basis of one gene. Like for example, if you see MRSA, that is medicine resistant staph aureus, it is not just only resistant due to MEC-A gene, it can be also due to MEC-C gene. So genotypic, this is the limitation of a genotypic method. That is, the resistance is not based on just on basis of genes. Also, even if the gene is detected, we are not sure, we are not reliable that the genes can be expressed or not. So phenotypic method is the gold standard for the detection of the antimicrobial susceptibility testing. Those genotypic methods have give rapid results. It also confirms the resistance mechanism, but the issue is the false susceptibility. Positive does not necessarily confer the phenotypic resistance. And also, the genotypic method is limited to some of the antibiotics only. So the gold standard is the phenotypic method, which is universally applicable. It is mechanism independent. It gives us the exact phenotypic categorization with therapeutic relevance. Therefore, we'll be discussing about phenotypic testing only in the further slides. There are different methodologies in AST phenotypic testing. Now, the selection of an AST method is based on numerous factors such as ease of performance. So, when we perform an AST by a phenotypic method, say about diffusion or dilution, we should see that it is easy to perform. That's one of the factors that should be considered for performing the testing. If stringent quality control measures are followed, we get an accurate results. So, AST should depend on factors such as ease of performance, the flexibility to perform the test, then its adaptability to automated or semi-automated systems, then also it should be cost effective. The results obtained from the phenotypic test should be reproducible and reliable. This is often an issue with the disk diffusion method that I will be discussing further. So the method should be reproducible, repeatable, and should be reliable. It should give us the accurate results as we use the results obtained from this method for the dosing of the antibiotics for the patient. So which are those phenotypic methods? Only few methods have been shown to be reproducible and repeatable, and this includes the disk diffusion method or the tablet diffusion, or the MIC or the broad dilution, which includes either micro broad dilution or a macro broad dilution, and also the E-test, that is exonometer test. Let us see through each of these methods. What does this AST provide? Standardized testing may provide either qualitative or quantitative results. If you use a disk diffusion method, then it provides as a qualitative result. Based on the diameter zone, we can interpret it as a sensitive or intermediate or resistant. This qualitative result indicates how a drug may respond to how an organism may respond to a drug in vivo. In resistant, the treatment failure can be expected. In intermediate, treatment is possible at high dosages. It is also known as susceptible dose dependent or susceptible increased exposure, or it can be interpreted as sensitive to success, wherein successful treatment can be expected at the approved dosage. Then we also get quantitative results in terms of MIC, that is minimum inhibitory concentration, from dilution methods and from the E-test. And then what is MIC? MIC is the lowest antimicrobial concentration that will inhibit the growth of, or kill the test organism over a defined range related to the organism's growth rate. Now let's see one of the most commonly performed method of this method, that is the Kirby-Bot disk diffusion testing, which is a common method used for the antimicrobial susceptible testing. Now this disk diffusion is based on the principle of diffusion of the antimicrobial into the agar medium, which is then counteracted by the growth of the organism present on the media. Now, what is this procedure mentioned? In this procedure, a paper impregnated with an antimicrobial disc is inoculated into the culture media. It is the Muller interim media that we use. A paper impregnated with antimicrobial is then inoculated into the culture media. Then the antimicrobial, as we can see from this image, the antimicrobial then diffuses into the agar medium, and then the race begins. This is the race between the diffusion of the antimicrobial into the agar medium against the growth of the organism. And at that point, we see a zone of inhibition. And based on this zone of inhibition, we interpret the results as sensitive, intermediate, or resistant by comparing with by referring to the breakpoints obtained from the CLS or the UCAS tables. So, particularly, this diffusion is more subject to, and then also there's an issue if you don't follow the quality control measures. This can give a false susceptibility test. For example, if the agar medium is too less, we can get a false negative susceptible results. Or if the depth of the medium is too high, you can get a false positive. So the depth of the agar medium can give us a false positive and negative sensitivity results. Also, the inoculum should be standardized. Too less or too more an inoculum can interfere with the results. So quality control measures should be stringently followed when we are doing a disk diffusion test. And the other method is the dilution method or the MIC method, since it gives the results in terms of MIC, which is the lowest concentration of drug that inhibits the growth of the bacteria isolated from the patient. Now, it can be done either by dilution by a micro broad dilution, or a macro broad dilution, or by agar dilution, or it can be done by the E-test method. In this MIC method or the dilution method, we culture the patient sample on a culture media, And from the colony, from the pure colony, we prepare a suspension. That suspension is matched to a densimeter with a half Macfarlane standard, and that the suspension is then inoculated to either in a microwells in a microbroth method, or in a tubes in a macrobroth method, or in agar place in agar dilution method. In a broth MIC method, once this suspension is inoculated into the microwave plates, we incubate it for an overnight, and the next day we observe for the clarity of the waves. As we can see from this image, when we interpret for the broad dilution, we first see for the growth control. If the growth control is passed, then we go for the interpretation of MIC in a broad MIC dilution method. If the growth control is not passed, we have to repeat the test. So, as we can see from this picture, we see for the growth control, then we see for the clear whales. The clearer whale is the MIC that we interpret. In these whales are arranged so that in the gradient concentration of the antimicrobial. In the first whale that you can see is a 0.06 concentration, then is a 0.1, then a 0.2, then 0.5, then 1. The 1, there is a clarity of the growth of the bacteria or the bacteria in this whale. So the MIC is 1 microgram per ml. So this is how we interpret the MIC in a microbroth dilution. It is clarity. Similarly is the application in agar dilution also. Here we don't use microwaves, but we use agar plates. We use a growth control plate in an agar, and the agar plates are prepared in such a way that they contain gradient concentration by antimicrobial. That, like you see in this picture, this agar plate contains 2 milligram per liter of antimicrobial, 4 and 8, and the agar plate shows clarity of the no growth of the bacteria refers to the MIC of the organism. You can do it by using tubes. As you can see, the application, the principle remains the same. The clearer whales refers to the MIC. Now, if you refer to the CLS or the ECAST method, if you do for a correlation of polymyxin, the recommended method is the broad dilution, not the agar diffusion. Because the issue with the correlation of the polymyxin is that it diffuses very poorly into the agar medium, and the recommended, hence we get a very false negative results. Hence, broad dilution is the preferred method as per CLS and ECAST for antibiotics such as colicin and polymyxin. Other method is the test, also called as epsilometric test. It is a quantitative method of antibiotic sensitivity testing. It applies the principles of both diffusion as well as dilution of the antimicrobial into the medium, and it gives us the MIC values. So this is an image of an epsilometric test that we do. This test consists of a polymer strip with gradient concentration of the antibiotic, which is placed on an agar plate, which is spreaded test pathogen. After an overnight incubation, the strip develops a zone of inhibition. It differs from the zone of inhibition of a curveball, wherein there is an ellipsoidal zone of inhibition. And at the point where the ellipsoidal zone of inhibition is over, that is taken as the MIC, as we can see from the picture. So the lowest part of the strip where the inhibition zone starts will be considered as the MIC. The graded concentration gives us a wide range and provides an accurate MIC. The peculiarity of this strip method that it gives a wide range of MIC as compared to the broad and the microbroad dilution method. And as per the MIC, then the pathogen is then categorized as susceptible, intermediate, or resistant. You can also do this antimicrobial susceptibility testing methods using automated systems like Phoenix and Vitek, that is the commonly used systems used in India. This is an advanced method of antimicrobial susceptibility testing, which is completely automated. Its broad microdilution method is used for the testing in the system. It also identifies the bacteria and provides the complete antibiogram of the pathogen isolated from the patients. So one of the we can apply the software to these systems, and we can also generate an antibiogram for the hospital or the healthcare organization. So, summarize about the antimicrobial susceptibility testing. In a disk diffusion method, a disk is used with a fixed concentration of antibiotics, is used as qualitative results in terms of sensitivity, intermediate, resistant, and the zone of inhibition is the interpreting criteria. However, the issue with the disk diffusion, it is a less reproducible. The data outcomes is less reliable because it is less repeatable and reproducible. The preferred method is the broad dilution. It is used as a quantitative result. Minimum inhibitor concentration is the interpreting criteria, and is the gold standard of antimicrobial susceptible testing. The other method is the e-test. It combines the principles of both diffusion and the dilution method. It is easy to perform, wherein paper strips with graded antibiotic concentration is used and is also used as the MIC value. And finally, the automated microbial systems, which is used for identification as well as the sensitivity method. It is an advanced method. It is based on the principle of broad microdilution method. It is quicker and provides us a detailed antibiogram. Now we have seen the different methods of antimicrobial susceptibility. Now let's see the interpretation. The main concept is the clinical categorization. There is a well-developed system of interpreting the results obtained from the antimicrobial susceptibility testing, and it is called as the breakpoint of antibiotics. Breakpoints help us to categorize the pathogen into either of the three categories, either as susceptible or intermediate or resistant. If, for example, if you get an MIC about 8 or lower MIC is 8 or a higher MIC is breakpoint as a lower breakpoint is 8 and higher breakpoint is 16. If the MIC is less than 8, we interpret it as susceptible. If the MIC is more than 16, we interpret it as resistant, and in between 2, we interpret it as intermediate. Now, how to interpret the intermediate category? Intermediate category in CLSI has expanded this term to susceptible dose dependent. In UCAS, we can see the similar term as susceptible increased exposure. In my opinion, susceptible increased exposure is a better preferred term because the dosing is more based on dosing of the antimicrobial is more based on dose rather than on exposure. Since susceptible increased exposure is a better preferred term. Sometimes the antibiotic can still be used in the intermediate category, when higher doses is required to ensure the efficacy. Antibiotic may be also efficacious if concentrated in vivo, as we can see if you use a nitrofurantoin in case of UTI. Sometimes there is an uncertainty. Intermediate resistance may represent a buffer zone that prevents the strains with borderline susceptibility from being incorrectly categorized as resistant. There is a column in the UCAS that's the area of technical uncertainty. If you get the results in such column, that area of technical uncertainty, we have to see where we have gone wrong before reporting to the clinician. We have to see we refer to the QC measures and see what was wrong with the test. If we get the results in the area of technical uncertainty column. Now, trained professional with good quality material can 90 to 95% of the time can attain a target MIC value of plus or minus 1 dilution. And also if you take target zone diameter of plus or minus 2 mm in size. Now we have seen the susceptible methods and how to interpret it. Now we interpret it with reference to the breakpoints. Now let's see in detail about the breakpoints. Let's listen with the agencies that let's see in detail about the agencies that determine the antimicrobial breakpoints. In the United States, the Clinical and the Laboratory Standards Institute, formerly the National Committee for Clinical Laboratory Standards, and the Food and Drug Administration are responsible for setting the breakpoint standards. In Europe, the main agencies are the European Union Committee on Antimicrobial Susceptibility Testing and the European Medicines Agency. The two main non-governmental agencies, that is CLS and UCAS, differ in the philosophy and approach towards setting the antimicrobial breakpoints, as well as in how they report to their suspected government counterparts, that is FDA and the EMA, that is Food and Drug Administration and the European Medicines Agency. Let us see the similarities and difference between the CLS and the UCAS in this table. The members in both the CLS and the UCAS include representatives from different fields and agencies. CLS is recognized by FDA, but FDA still determines its own breakpoints. Breakpoints determined by FDA can be modified by CLS after 2 years. UCAS functions as a breakpoint committee for European Medicines Agency. CLS guidelines are a part of a decision process, while UCAS serves as a consultative role. The decision making in CLS is by consensus by group votes, while decision making in UCAS is a consensus of executive committee. There is no voting. The funding in CLS is from government and the sales of documents, while funding in UCAS is from European Society of Clinical Microbiology and Infectious Diseases and European Center for Disease Control, and from the government. The data and the rational documents are available on the CLS website. However, it is a paid thing. So it's for sale, while it is free in the UCAS. The meetings in CLSI occurs every 2 years, while in UCAS it occurs every 5 years. Now let's say about the main thing of the breakpoints. CLSI mentions about its clinical breakpoints and retains its intermediate category, expanding the intermediate category to the term susceptible dose dependent. While in UCAS we see also UCAS clinical breakpoints and the intermediate term replaced by susceptible increased exposure terminology. It often is there's a question why is so differences in the interpretation between the CLS and UCAS. The CLS and the UCAS, the testing conditions in the CLS and UCAS are different. Actually, if you refer to the guidelines, the testing conditions are different. This may be the one of the reasons for the discrepancies. They come with the updates at regular intervals, but the updates are not coordinated. That may be another reason for the discrepancy in the CLS and the UCAS interpretations. If you refer to the CLS website, it consists of, let's say, the reference matters in the CLS website. The CLS website, if you see the M7, it mentions about the methods of dilutional antimicrobial testing for bacteria that grow aerobically, while M2 mentions about the performance standard for disk susceptible testing, while M45 is for the fastidious organisms. M100 is the performance standards informational supplement. We CLS also do standards for the pathogens for the bacteria, also for the animals. Similar in the UCAS, we get the general information on the performance of the test, the implementation guidelines, the methodology for the preparation of the media and the test, performance testing, and the interpretive criteria, the diameter distribution, the MRC distribution, the ECOF values, and the QC tables. Now let us understand the breakpoints. We have seen the agencies that determine the breakpoints. Let us understand the breakpoints now. Every category that is sensitive to intermediate resistance specifies the possibility of successful treatment of pathogen by a particular antibiotic. These categories are decided on the basis of breakpoints. Now, what is the process of establishing a breakpoint? This is very crucial as it is the main driver of antibiotic treatment. And now let's see how the breakpoints are determined. Breakpoints are determined using the following multidisciplinary approaches. Step 1 is the microbiological data is used to establish the epidemiological cutoff. That is the most important first step. That is epidemiological cutoff is established. Then we move to the second step that we define the PKP, the indices from the PK from the pharmacodynamic and the pharmacokinetic parameters. And the third is the clinical. Based on the clinical outcome, we then determine the breakpoints. Now let us first go to the first step, that is the epidemiological cutoff value. It's abbreviated as ECV in CLSI guidelines or ECOF in UCAST. It's the ECOFs are the measures of a drug MIC distribution that separate a bacterial population into those representative of a wild type population and those with an acquired or a mutational resistance to the drug. This graph will make us easy to understand the epidemiological cutoff. If you see this graph, MIC distribution of the antibiotic is plotted, and based on this MIC distribution, the ECOF is determined. And such so for if you see this graph, below this ECOF MIC point, ECOF, there is a wild type population that doesn't have any mutational or any resistance mechanism. But above this ECOF MIC distribution, we see an inherited resistance or a mutational or acquired mechanism of resistance. We'll explain now. The ECOF defines the upper limit of susceptibility for the wild type population of isolates. In the wild type population, the ECOF interpretive category defined by an ECV includes isolates with no mechanism of acquired resistance or reduced susceptibility for the antimicrobial agents being evaluated. While in non-wild type, the ECV category is defined by an ECV that describe isolates with presumed or known mechanism of acquired resistance. In this graph, in this MIC distribution, we only just come to know a wild type population without an inherited or mutational or acquired resistance, or with a population that is non-wild type with an inherited resistance or mutational or acquired mechanism of resistance. It doesn't give any idea to us about an PKPD, that is a pharmacodynamic or the pharmacokinetic parameters. Hence, it helps us to know only with a population with a resistance mechanism and without a resistance mechanism. Now, what are the conditions that must be required to generate this ECOFs? The most important is that the ECOFs can be determined only with a single species. Because of the genetic diversity among the species within a genus, ECV can be determined only with a single species. MIC values included in the data set of an MIC distribution must be determined using a recognized reference method such as CLSI MIC broad dilution method, that is M72. M72 should be the reference standard for including the MIC values in the distribution for determination of the ECOF. Then the data must be sourced from at least 3 separate laboratories, and there should be at least 100 unique strains included in the merged MIC distribution. And not more than 50% of MIC should be generated from a single laboratory. As much as possible, the MIC values included in the individual lab data must be on a scale. That is, must be on a scale. That is, the data should be able to be analyzed. This condition applies particularly to MICs of the presumed to wild type strains. Now, before merging the data for ECV estimation, the MIC distribution from each individual laboratory is inspected, and if the lowest concentration is more, then the data is not included for the calculation of ECOF. Now, once acceptable data are merged, once we get the MIC distribution, a number of methods are used to estimate the ECV. The method used to determine the ECV should be described. The simplest method is visual inspection, which generally works for MIC distribution when there is a clear separation of wild type and non-wild type. But when there is no clear separation between wild and non-wild type, then we take help of the statistical methods. Such as iterative statistical methods is commonly used, which the statistical methods should be considered to remove any potential observer bias from the estimation. Several methods have been proposed, and the sponsor should mention the method used for the ECOF determination. Estimation of ECOFs from the MIC distribution may also be supplemented with molecular test, which confirms the resistance mechanism. So the M73 is the guidance that can be used for the determination of the ECOF values. Now, from this graph, you can see that the population is almost a wild type, with 95% of the population in there being a wild type. That is, they don't have any mutational or acquired resistance mechanism. It's 95% of the population that belongs to the wild type. The ECV is 0.125, is well below the indicated CLSI and the UCAS breakpoints. I repeat again, ECOF should be used only to determine the wild type and a non-wild type population, that is with an inherited mechanism of resistance or without an inherited mechanism of resistance. For example, now will I give you an example. Say about TJ-cycline against Pseudomonas, TJ-cycline MIC against the Pseudomonas isolates. The TJ-cycline MIC is 32, while the CLS and the UCAS breakpoint is 64. Though the ECOF is 32 of TJ-cycline against Pseudomonas, it cannot be used for treatment. So even if the ECOF is less than the CLSI or the UCAS breakpoint, it cannot be used for the treatment. Vice versa, if the ECOF is more than the CLS and the UCAS breakpoint, it can still be considered for treatment. For example, Streptococcus pneumonia, azithromycin cutoff for Streptococcus pneumonia is about 0.25. Also, the CLSI breakpoint is 0.25, while ECOS is 0.5. Though the MIs and the cutoff are the same at a level, if the PKPD targets are met, if the clinical outcome is good, the ECOF can be considered for treatment. This is the ECOF finder. That is a software that is used for the ECOF determination. If you can get an access to the ECOF finder in the UCAS website. The ECOF, for the ECOF, to use the ECOF finder, we have to put a organism name in the left column and in the antibiotic in the column, and then enter the raw count of the isolates obtained in accordance with the MIC values. So we add on the raw count of the isolates as per the MICs, and then we set up the ECOF percentage, that is 95% or 97 or 99%, and click on the solve button, and we get the required ECOF values. So this ECOF finder can be used for the automated determination of ECOF value, which is based on the iterative statistical method. Now, how we will speak on the guidance for the interpretation of ECOF. ECOF are normally used to determine, I repeat, for a wild type and non-wild type, that is strain that belongs to normal distribution without a resistance mechanism, or a non-wild type which harbors a resistance determinant. As you can see from this graph, the MIC values used and distributed for a determination of the ECOF. Similarly, we can have a diameter zones for a determination of the ECOF value. Here also the interpretation remains the same, that the strains belong to a normal distribution for particular species. In a wild type and a non-wild type, it is likely to harbor a resistance mechanism. You can see that it's a reverse. Wild type you can see on the right side, while it was on the left side in the MIC. Now, if you refer to the CLSI 100 S20 tables, G1, G2, G1 to G3, you can see the ECOF values for azithromycin for Shigella flexneri. wherein it for the wild type the ECOF value is less than 8 microgram per ml, but for the non-wild type it is more than 16. Similarly, we have the ECOF values for the colistin that is less than 2 for wild type and more than 4 for the non-wild type. Similarly, we have the ECOF values for Neisseria gonorrhea, wherein azithromycin ECOF is less than 1 or more than 2 for non-wild type. Now, if you want to guidelines on reporting of ECV, we refer to the MPPSM document of CLSI. You can see from this example that is Anidoctrin and Candida lucitinia. There are currently no breakpoints for individual criteria for Candida lucitinia against Anidoctrin fungin. The Anidoctrin fungal MIC is about the wild type MIC. The MIC is more than ECV, which suggests that this isolus may have acquired a mechanism of resistance and could be considered non-wild type. However, if it is to be considered for treatment, the clinical implication of finding a non-wild type is currently unknown. If the agent in question is being used for treatment, then the patient should undergo clinical review in consultation ID physician or a clinical pharmacist. What does the MPPSM guidance say about applying ECVs? It says that when not to use an ECOF value, ECOF should not be used when breakpoints have been already published. ECOF should also not be used as a strong predictor of clinical response to therapy, but rather as an indicator of possible acquired resistant mechanism which could affect response to treatment. Now, what is the problem with ECVs during the breakpoint? As I said, with an example of tetracycline and Pseudomonas and azithromycin or Streptococcus pneumoniae, that is, ECOF does not account for the PKPD or the clinical response correlation. Just because an isolate is a wild type, therefore has no resistance mechanism to an antimicrobial, does not mean that the concentration are adequate or that PKPD targets are met. Conversely, just because an isolate is a non-wild type and has a non-resistant mechanism does not mean that the PKPD targets are not met. Therefore, there is a need to make certain that labs do not report or imply that ECVs or ECOFs predict clinical response, otherwise the patient may be harmed. The concentration range tested for, let us see about the pharmacological concept of the breakpoint. The concentration range tested for a drug and the interpretive criteria for various categories are based on extensive studies that correlate with the serum achievable levels for each antimicrobial agent and on the particular resistant mechanism and successful therapeutic outcome. In practical situation, the entire range may not be used for decision making, and therefore a breakpoint is needed. Now, let's come to the second step. How to determine a after we establish ECOF values. Now, how the second step we get a PKPD indices. For the PKPD indices, we do a pharmacodynamic study and a pharmacodynamic study. The aim in pharmacokinetic study is to determine the time concentration profile in different fluids, describing the process of adsorption, distribution, biotransformation, metabolism, and excretion of drug. Now, what are the parameters that we get from the PK study? The parameter that we get, the common of the parameters is free drug in the area under the curve concentration, free drug concentration in the area under the curve, then the concentration, then the maximum concentration of the free drug, then the half-life of the drug, and the creatinine clearance, and the volume of distribution. So these are the parameters that we get from the PK study. In pharmacodynamic study, the objective is to define the relation between the drug dose or the concentration and the response or the effect. So from the pharmacodynamic study, we get maximum effective dose, then the ED50, that is the effective dose in 50% of the target population, then the MIC 90, that is the minimum millimeter concentration required to kill 90% of the organism. So Emax, ED50, and MIC 90 is the parameters that we obtain from the PD study. Then using this PK and PD, that is pharmacodynamic parameters, we then go to define the get our indices. And let's see about these indices. Pharmacokinetic parameters is a Dynasys indices is the relationship between the pharmacokinetic and the pharmacodynamic parameters. If you see this graph, then the concentration of the antibiotic is plotted against the time. Here, one pharmacokinetic index is the maximum concentration of the free drug to MIC. The second PKPK index is the area under the curve of the free drug to the MIC. And the third is the time interval where the free drug remains above the MIC. I repeat again, one PKPK index is the concentration of the free drug that remains above the MIC. Second is the concentration of the free drug in the area under the curve over a 24-hour period to the MIC. Then the time interval where the drug remains above the MIC. So these are the three PKPK indexes that is commonly used. As I said before, I was mentioning about the free drug, free drug. If you had, when I use this term free drug, I use the abbreviation F. F stands for the free drug available after protein binding. The protein binding drugs are not available to exert that pharmacological effects. It is only the unbound free drug concentration which can exhibit the pharmacological effects. 90 to 98% of the protein binding has twice the exposure difference. As we can see from this image, when a drug enters to a vessel, it binds to a protein. If it is binds to a protein, it's not available for this action on the effector cells. But if it skips the protein binding, it is available for action on the effector cells. Now, based on the PK indices, we have three classes of antibiotics. One is the concentration dependent, another is the time dependent, and the third class of antibiotics is the concentration as well as time dependent. In the concentration dependent antibiotic group, we have antibiotics like aminoglycoside, fluoroquinolones, metronidazole, daptomycin, polymyxin. In this, the peculiarity of this concentration dependent group of antibiotics is that we use the PK indices such as Cmax to MIC. Now, what is Cmax to MIC? It is the indices which states about the concentration of the maximum free drug concentration. If you want to have maximum optimal action of the aminoglycoside, we should have the Cmax to MIC value of at least about 8 to 10. Because this group of antibiotics has a long post-antibiotic effect. Once we administer a dose of aminoglycoside, that dose goes over the 24-hour period because of the long post-antibiotic effect. We don't have to give that. This is the principle that is used for in antimicrobial stewardship program, wherein the strategy is once a daily dosing of aminoglycoside because of the high free drug concentration of the aminoglycoside because of the long post-antibiotic effect. Similarly, we have time-dependent antibiotic group, which includes penicillins, cephalosporins, and carbapenems. In this, the difficulty of this time-dependent antibiotics is that the more the free drug concentration is about the MIC for during the duration of during the time interval of the dosage, the more the effect of the optimal action is of the time-dependent antibiotics. For example, for optimal bactericidal activity of cephalosporins, the free drug concentration should be more than 60% over the duration interval. For penicillin, it should be more than 50% of the duration interval. While for carbapenems, it should be more than 40% of the duration of the time. The free drug concentration should be more than the MIC. I repeat again, the free drug concentration in time-dependent antibiotics should be more than MIC for more than 60% in cephalosporins, more than 50 in penicillins, and more than 40 in carbapenems. It's for bactericidal activity. For the bacteriostatic, the cephalosporins free drug concentration should be more than MIC for 40% of the time interval, while for penicillin it is 30%, while for carbapenems it is 20%. So that is about the time-dependent antibiotics. It depends on the interval. It's not dependent on the concentration. Similarly, we have concentration at a time-dependent group of antibiotics like fluoroquinolones. Now, the fluoroquinolones, since it is a nephrotoxicity, we see the area. We give special attention to the area under the curve of the MIC. The area under the curve of the MIC, the value for fluoroquinolones is used for the calculation for the dosing of the antibiotic. Regarding the fluoroquinolones, the ratio of the area under the curve like in case of ciprofloxacin, the area under the curve should be more than 1 to the MIC should be more than 125 for the gram-negative pathogens. But similarly for levofloxacin, the ratio of the area under the curve to the MIC should be more than 125 for gram-negative infection. While for the gram-positive infection, the area under the curve to the MIC ratio should be more than 30 for gram-positive infection. Now we have a group of antibiotics like for vancomycin, which is concentration dependent and time dependent. Within the area under the concentration curve to MIC ratio for vancomycin was 400. Now let's see to this graph the concentration dependent, time dependent antibiotic versus the Pseudomonas aeruginosa. As we can see from this graph, this is the control line. this dosage is 1/4 of the MIC. This is 1 MIC. Then this is four times the MIC dose. When we increase the doses of the antibiotics 4 to 8 times to 16 to 64 times, we can see in the case of tobramycin as well as in the case of ciprofloxacin, as we increase the dosage of the antibiotic, the rate of bacterial cell killing increases. Also, the time interval required also decreases. While it is not the case in ticarcillin, that is a beta-lactam antibiotic, as we increase the dose of the antibiotics, the there is not much significant difference in the time interval, the dosing interval, or in the rate of the bacterial killing. That is which concludes that ticarcillin, the beta-lactam antibiotics are more time dependent, while the aminoglycoside and the fluoroquinolones are more concentration dependent antibiotics. Now let's see what is the in vitro in vivo correlation. We have seen the embryologic cutoff, we have seen the PKPK parameters, and how do we the importance of the PKPK indices. Now, what is the in vitro in vivo correlation? In Europe, the clinical breakpoints are set by the UCAS and following a defined procedure, which includes defining a PKPD target, a magnitude for a PKPD index at which a desired level of predicted response is derived from the non-clinical and clinical studies. Then the Monte Carlo simulation is then applied. What is Monte Carlo simulation? When a PDT has been identified, that the pharmacodynamic target is identified, it is necessary to assess whether this applies across a typical patient population. Pharmacodynamic data may not be available when simulations are first attempted, and patient data may be limited to relatively small numbers when dosing regimens are selected. Therefore, statistical approach is required to simulate individual patient PKPD profiles for the inputs, which includes measures of central tendency statistics for PK parameters and their associated variance. The statistical method often uses Monte Carlo simulation. In other words, Monte Carlo simulation is used to estimate exposure of the antimicrobial agent in the target population and commonly used dosing regimens. And using such simulation, it is possible to estimate the probability of attaining the pharmacodynamic target when MICs of the test agents are within a range observed for the pathogens relevant to the intended clinical uses. We'll quickly go to the slides. Now, this is the most important slide which will help us to see how the dose, this PKPK indices indices and the breakpoints is used for the dosing. Now, the CLS and the UCAS susceptible breakpoint for meropenem against Pseudomonas is 2 microgram per ml. Now, this breakpoint is based on a standard dosage regimen of 1 gram every 8 hours. Now, this data, as we compared to the previous slide, I will not go to the slide, but it stated that 90% of the pharmacodynamic dynamic targets were achieved at this dosage of 2 microgram per ml with this dosage of 1 gram every 8 hours. However, the same data shows that the 2 gram every 8 hours, here we have used 1 gram every 8 hours at an MIC of 2 microgram. But when the MIC is 8 microgram per ml, even the dosage of 2 gram every 8 hours dosing regimen have achieved more than 90% of the targets. So this is very critical to understand. For such time-dependent antibiotics like meropenem, increasing the duration of infusion or increasing the frequency of intervals of dosing or giving a loading dose in the beginning can help us to give an optimal dosing if the MIC is higher. So this is critical to understand that all breakpoints are dose dependent, and as we change the standard dosing regimens, the breakpoints would also change. This is particularly important for multi-drug resistant organisms, limited treatment option. A pathogen with an MIC of 8 is resistant to the standard dosing regimen of meropenem 1 gram, but can be deemed susceptible to a higher dose of 2 gram without compromising on the pharmacodynamic targets. Hence, in the clinical setting, this breakpoint should be looked with respect to the dosing regimen. So, we'll give an instance. The piperacillin tazobactam, which is an antibiotic used for the empirical therapy of Pseudomonas, which is an Helicobacter pathogen. The MIC was 64, which has been recently the breakpoint was 64, which has been, but at this breakpoint of 64 of peptides against the Pseudomonas, there was a high incidence of mortality, and the breakpoint was recently reduced to about 16. So such breakpoints needs revision too, based on the clinical outcomes. And now finally, to summarize, we get preclinical PKPD studies from the microbiology data and the clinical PKPD studies from the clinical outcomes. Then we correlate with the exposure and the effect, which which help us to determine the pharmacodynamic target. And this correlation includes analysis of the quantitative as well as the quality relationship between the PK/PK indices, which help us to determine the clinical dosage regimen. Then finally, the Monte Carlo simulations then applied to the PK/PD target indices to give us the initial PK/PD breakpoint. Then to the initial PK/PD breakpoint, then we, in reference to the MIC distribution, we applied the Monte Carlo simulation robustness in the target population with those adjustments to finally give us the PK/PD breakpoints. Finally, UCAS reconsiders PK/PD breakpoints when indications change significantly, as I said before, and or when dosing regimens change significantly. So that was how we determined the breakpoints. The first step was the establishing the ECOF, that is the economic cutoff values. Then the second was the determination of the PK/PK indices, and then finally on the clinical outcome we determined the breakpoints. In any case, now let's conclude with the guidelines for the therapeutic decision. In any case, the results of the antimicrobial susceptibility needs to be interpreted with some background knowledge on the biology of the organism and the patient history before treatment is prescribed. Do not use the antimicrobials if they are not necessary. There is a judicial use of the antimicrobials. Always take into account the intrinsic resistance. Most of the organisms which have now become common, like enterococci, which is or enterococci or Burkholderia, like so for example Burkholderia, which is healthcare pathogen, which is intrinsic resistant to colistin, or enterococci, which is intrinsic resistant to aminoglycosides, cephalosporins, cotrimazole. So this intrinsic resistance should be taken into account, and this we'll get this while determination while selection the antibiotic against pathogen. We'll get to know about the most common organism prevalent in the healthcare organism if we refer to the hospital antibiogram. So we should always take into account the intrinsic resistance and do not use any antimicrobial if they are not necessary. Check for any unusual results. If you have any unusual results, then review the methodology used for the determination of the antimicrobial testing results. And then the patient history is very important. One thing, we'll put an example here. If penicillin with an MIC of 0.5 was reported as a sensitive in the lab, but the sample was CSF sample of a patient with suspected meningitis. It was misinterpreted as sensitive. But when the clinical, when the CSF guidelines was referred, it was found that the CSF breakpoint is much below the 0.5. That is was around 0.2 was much below the MIC, and then it was rectified. So such errors needs to be avoided. Particular attention needs to be given to the sample that is being used for the scientific testing, and the patient history is very important. The underlying diseases and the previous treatments. So the MIC interpretations differ from bacteria to bacteria as well as from drug to drug, and sample needs to be should be taken note of. And the drug choice needs to be taken into account the drug properties and the distribution for the predicting the efficacy of the target organs. We should always take into account the drug properties as well as its distribution. Where is the distribution of the drug? Whenever it is the intermediate, we can use it if it at a higher doses. The dosage adjustment should be precise for avoiding sublethal concentration and toxicity issues. Whenever possible, use a narrow spectrum drugs and reserve some of the important drugs like colistin or tigecycline for human use for use in exceptional cases. The resort antibiotic strategies should be followed in a healthcare organization with another controlled condition. If want to prevent and control the development of the resistance. So that was some of the few guidelines for therapeutic decision based on the EST results. That concludes my talk. I thank all of you, the participants here, for the kind attention, and we'll appreciate questions towards the end of the webinar. I'll hand over the session to Dr. Pankaj.
Thank you. Thank you so much, Dr. Rahul Kamble, sir, for your wonderful presentation. There are a lot of take-home messages to be taken, and that's the beauty of having a speaker like you in this session. Just to touch base a little bit of summary what Dr. Rahul Kamble just said now. He was talking about a little bit on the AST and why is it necessary, some points on the phenotypic and the genotypic mechanisms, the MIC interpretation, and the automated systems, which are very useful nowadays in interpreting the breakpoints or the MICs. He also mentioned about the gold standard, the agar or the broth microbiology dilution method. Specifically, he also mentioned there are two important organizations like the CLSI and the UCAST, who the world follows. Even in India, these guidelines have been followed very seriously. Moreover, he was talking about how are the breakpoints considered, how are they made. Just to give a few points, he was talking about the epidemiological cutoff, the PKP indices, which are very important, and the clinical outcomes as well. He was also trying to correlate between the in vitro, in vivo correlation in regards to the PKPD target indices, as well as the multipolar stimulation and so on. The best part I really liked in this presentation was his talk that the breakpoints should be looked in respect to the dosing regimen, because now recently the ID has suggested, especially for meropenem, that the 2 grams tedious dosage should be considered in patients who are suffering from multi-drug resistance bacteria, not for cystitis, but rest other bacteria who are susceptible to meropenem as well. So thank you so much, Dr. Rahul, for such a wonderful presentation. Lots of points have been cleared from your presentation. We have got lots of questions as well. As you rightly said, we will be taking those questions at the end of the session.